at Congenital Heart Academy YouTube channel. So it helps me to see what I'm going to talk about that specific topic. So really, it's been very helpful. We have more than 10,000 subscribers. Thank you a lot for all of you to be there. And just remind you, Dr. Anderson is making an amazing series, and we are going to talk about development of outflow tracts in the end of April. So please join. It's been a very, very nice series as usual. And I'd like to invite all of you to share your research in the May edition of the Children's Journal. Sasha and Dr. Luciana Fonseca are the guest editors of this issue that is going to talk about the advances in the pediatric cardiac surgery. So please send your manuscript until the beginning of May. We are all going to be very happy to review and to publish your research.
Sound is not good.
We're missing the music, Grace.
Oh, okay.
So if you guys scan this QR code, it's going to take you to the website of the World Congress. The World Congress is going to be in Washington, D.C. from 27th of August to 1st of September. It's an entire week of a lot of knowledge and sharing experiences. I really, really want to see all you guys there. It's going to be an amazing, amazing meeting. Gil and Dr. Jacobs are really working hard, and all the executive committee is really working hard to make this an experience of a lifetime. So guys, please try to join us in Washington. The registration is already open. We have the early bird fee, so it's a good moment to make a registration right now. And the abstract submission is open as well. And we are going to be happy to see your research there as well. And now we are going to start. Dr. Rima is going to tell a little bit about today's meeting with 3 outstanding Brazilian doctors. I'm very happy to have all of them here today, and I'm sure this is going to be an amazing meeting. If you find this interesting, please share the link of YouTube with your team, and please type all of your questions on the Q&A chat box. Dr. Silverman is with us today, and the speakers, they all are going to be happy to answer your questions. So now, Rima, with you.
Thank you so much, Grace. I'm very glad as you know, Grace is Brazilian, and the team today is from Brazil. They're colleagues and friends to all of us, very famous. And I'd like to introduce, and also I'd like to apologize for the time difference, and that's why we had a little bit of technical issues. This is our 23rd episode of our Fetal series under the Congenital Heart Academy and the Gulf Heart, Fetal Gulf Heart Association, and we're going to discuss a very important topic, borderline left ventricle. And I think the word borderline explains the challenges that we're going to talk about, starting from the fetal life till the postnatal life. And Simone is going to talk to us today. And she's a consultant pediatric cardiologist and the head of the fetal heart unit at the Hospital of Dr. Sico in San Paulo. Please proceed, Simone.
You are still muted here.
Oh, okay. Can you see my slides?
Yes, now I can
Yes,
hear you.
we do. Yes, we do.
Okay,
Everything is fine.
perfect. So, first of all, thank you all for the invitation to participate in this amazing meeting. Congenital Heart Academy has been excellent and a very good way to learn and to share information. And I'll start with my talk, and it will be the borderline LV from fetal to postnatal life. And my talk will be on fetal and neonatal presentation and management strategies. So what's a borderline LV? It's a spectrum of left ventricle underdevelopment, typically associated with some cardiac anomalies like aortic valve stenosis, aortic coarctation with or without hypoplasia, hypoplastic aortic arch, hypoplastic left heart complex, and right ventricular pressure or overload volume overload in some conditions. So here we can see a very mild hypoplasia in this spectrum, and the severe hypoplasia, and then in the middle we see the borderline LV. With kind of smallish LV, ascending aorta, and aortic arch. There are two borderline left heart phenotypes in the fetus. One is related to severe aortic stenosis, which is associated with a globular and fat LV, and there is systolic and diastolic dysfunction of the LV, and this LV stopped to grow. It's a grow arrest, and it was dilated before. And the other presentation is the hypoplastic left heart complex, which is associated with a long, skinny LV, laminar flow across the hypoplastic mitral valve and aortic valve, and arch hypoplasia with no aortic stenosis and good systolic function. And we see retrograde aortic arch flow in this setting, suggesting inadequate antegrade aortic flow. So starting with critical aortic stenosis, we know that fetuses with this disease are at risk of intrauterine growth arrest of the left ventricle, ultimately leading to hypoplastic left heart syndrome. So this is a second trimester dilated LV, very severe EFE, and the third trimester, we can see the hypoplastic LV. And this is a case with 23 weeks. And we know that achieving biventricular circulation without intervention, it's very unusual, because when we have moderate LV systolic dysfunction, retrograde aortic arch flow, and abnormal foramen ovale flow with left to right or bidirectional. And so these are the markers. So which are the echocardiographic features of the critical AS? Thick aortic valve with low mobility and high velocity thin jet across it. Endocardial fibrolastosis is present in all cases, and it negatively affects the left ventricle growth, geometry, systolic and diastolic dysfunction with increased diastolic pressures. And because of this diastolic dysfunction and elevated diastolic pressure, there is a short duration and single mitral valve inflow Doppler. The flow in the foramen ovale is left to right with some potential for foramen ovalean restriction. And when the foramen ovale is restricted, we have to look at the pulmonary vein Doppler, and it can be very abnormal, like this example. And we can calculate the forward to reverse VTI ratio, and this is the worst spectrum, and this is the best spectrum. And you know, when this ratio is below 3.5, there is risk of severe disease in the neonatal period. And then we can see retrograde flow across the aortic arch. As we see here, this is the ductal flow, and this is the aortic arch, and is completely retrograde. We can grade the EFE severity according to this study from Boston group, from none to severe, and it can be mild, moderate, and severe. Severe is a contiguous echogenic lining of the LV, as we see here, and mild scattered echogenic spots within the left, including the mitral valve and papillary muscles. They are the first ones affected, and the moderate is the middle, in the middle of the two features. The other index that we can assess is the LV sphericity index, and this can be calculated by dividing the short axis diameter through by the long axis diameter of the left ventricle, and when it's closer to 0.5, it's better. So we see one example of a globular shape, and this is a better case with a shorter sphericity index. And to assess the capacity of the LV to generate pressure, we can measure the LV to aortic gradient. And if there is MR, we can assess the mitral valve peak velocity and gradient. So the measurements that should be taken are all of them: aortic valve annulus, ascending aorta, left and diastolic diameter, left long LV long axis, mitral valve annulus, RV long axis, and the ratio of the long axis of RV to LV, and of course, putting them on the Z-scores according to the gestational age. And remember that the ASD size is very important, and if the ASD is very unrestricted, it may unload the LV and make it smaller than if it is restricted. The other spectrum is the left heart hypoplasia complex, and this is the fetal presentation. The right heart is significantly bigger than the left. The LV is skinny, small short axis diameter, normal LV function. There is no EFE, smallish mitral valve, mitral and aortic valves with no flow obstruction, ascending aorta in aortic arch with different degrees of hypoplasia, and reverse flow in the transverse arch. So I can show you here one example of this: a smallish LV, no apex formation, normal LV function, normal flow across the mitral and the aortic valves, biphasic LV in flow, and there's a normal aortic valve, although in a small side, and retrograde aortic arch flow, with the three-vessel view showing a great discrepancy between the pulmonary trunk and the ascending aorta. And this is the arch. Normally, there is a coarctation or arch hypoplasia with retrograde flow across it, as we see. So what can be done prenatally for borderline LV? Fetal aortic valvuloplasty for critical aortic stenosis. Is it feasible, and is it worthwhile doing? And it can be associated with maternal hyperoxygenation, or if we have the left heart hypoplasia complex, we can think about maternal hyperoxygenation. So, which are the biventricular predictors of biventricular circulation in fetal aortic valvuloplasty? Let's have a look at the literature. And this is not for borderline LV. This is the Boston's group publication. And we see that what matters most is the capacity to generate pressures. And after that, they divide it into groups. And we see the ascending aorta, mitral valve annulus, inflow time, and long axis of the LV. And the predictors of biventricular at birth had the higher chances are when the LV pressure is greater than 47 millimeters and the ascending aorta Z-score is greater than 0.57. So this is the ability to of the LV to support the systemic circulation. So they have to, it has to have the adequate LV pressure, high mitral valve inflow time, so not very bad diastolic dysfunction, large ascending aortic dimension, and long axis dimensions. This is the group from Austria, Linz, and they published recently 103 fetuses with 88 live burn, and the predictors for biventricular circulation were the ratio of the RV and LV long axis being less than 1.094, or again, associating the LV pressure with this velocity and 39 millimeters of mercury. And remember that these measurements have to be performed in diastole and diastole. So I've shown some fetal intervention in borderline LV, some cases we've done in São Paulo, Brazil. So this is a 30th week gestation, and we see that there is no apex formation of the LV, severe EFE grade 3, and the sphericity index very high, 0.85, which was a borderline LV on all the measurements. And we see here the EFE, aortic valve very thick. The gradient was 40, very little time inflow mitral valve, and normal pulmonary vein Doppler. So we performed the aortic valvuloplasty, and the following day we could see better flow across the aortic valve, very bad function, still better inflow time, and some antegrade flow across the aortic arch. So this baby then was born with a borderline LV, and there was still gradient across the valve. The function was good, as we can see here, and we decided to just dilate the valve. The pressures in the cath lab were this. Look at the end diastolic LV pressure was 18 millimeters per mercury, and after dilation, it came down to 12, and the gradient went down. And 6 months later, we can see a high ASD velocity flow, so very high LV pressure, and like an arcade mitral valve, and kind of a borderline LV, and there was severe mitral valve stenosis, severe pulmonary hypertension, and there was still some aortic stenosis. The systolic function was good, and unfortunately, this baby died during the aortic and mitral valve repair. So we believe that this baby would have better chances if the hybrid procedure was performed first. This is the second case that I would like to show. It's a 24-week gestation with severe mitral regurgitation and restricted AHD. Again, no apex formation of the LV and severe EFE, sphericity index of 0.7, and some pericardial effusion, so high drop was approaching. ASD was restrictive. We see the pulmonary vein Doppler and severe mitral regurgitation. So we proceed with the aortic valvuloplasty, as you see here, and with 35 weeks gestation, the left atrium was decompressed. There was good antegrade flow, but the function was very bad, still very bad, but very much better pulmonary vein Doppler. And the baby was born. This is the neonatal echocardiogram, and we see bad function and still a severe aortic stenosis, so we could improve the pulmonary edema. However, there was still a critical, very severe AS. We can see antegrade flow in the aortic arch, and the decision was to perform aortic valvuloplasty followed by a hybrid procedure. The baby needs atrial septostomy due to persistent pulmonary edema, And we see after decompressing the left atrium, the LV was really small, and then we follow the univentricular tract after that. And the third case I'd like to show was 27 weeks gestation. It was a hypoplastic LV, so the ratio was 1.5, EFE grade 2 to 3, sphericity index of 0.5, so much better, as you see here. And you see all the numbers, the pressure, according to the mitral regurg, was 21 millimeters of mercury. There was a nice looking aorta. The septum was a little bit better than the other parts of the ventricle. We did the procedure and we see the mitral valve moving better, flow, antegrade flow across the aortic valve, and no restriction at the atrial level. She had 3 courses of hyperoxygenation, neonatal hybrid, and no new aortic valvuloplasty was performed, and this baby reached biventricular circulation at 9 months of age, and recently had a surgical aortic valvuloplasty because of aortic regurgitation. So this is the neonatal presentation. You see it's very small LV still, but unobstructed aortic valve. After hybrid procedure, we see the LV was in much better shape, as we see here. And before biventricular repair, this is the MR showing a nice looking LV. And this is the TE during the procedure, the biventricular repair. Marcelo is going to talk more about that. So in conclusions, cases of borderline LV and fetal intervention, EFE grade and sphericity index seem the major fetal presentation difference between these 3 cases. EFE damages the mitral valve apparatus, and deal with mitral valve disease is a major problem in infants. So staged biventricular circulation seems safer in this group of patients. This is our experience with fetal aortic valvuloplasty. So we have done 46 fetuses with 5 fetal deaths and 11 neonatal deaths. Of the 30 neonates survived, 20 were biventricular. As we see here, 7 of them needed staged after hybrid. And we lost of this 8 patients, 4 with biventricular, 1 with staged before, and 4 univentricular. And we have 1 patient that was transplanted. Maternal hyperoxygenation is another tool that we can use during gestation. It's a diagnostic and therapeutic tool that have been used for many conditions, such as improved development of fetal growth restriction, and in congenital heart diseases, like left heart diseases, to improve development of the lung, heart, and brain, and pulmonary circulation vasoreactivity assessment. These are all the studies related to maternal hyperoxygenation that were published, some of them therapeutic, some of them only diagnostic tool. And the rationale is the oxygen may provoke fetal pulmonary vasodilation in response from nitric oxide synthesized during maternal hyperoxygenation, which increase pulmonary venous return and increase the left heart filling, remodeling the fetal left heart. So let me just show, this is an interatrial septal aneurysm, just show the effect of acute hyperoxygenation. You see the septum bulging to the right side after the hyperoxygenation, and feeling better the left ventricle. So we had a case, this is a case presentation. We have this case with small LV, no apex formation, normal LV function, left to right, show at the atrial level, normal flow across the mitral and aortic valves, and heterograde flow across the aortic valve. As we see here, heart hypoplasia, and we performed hyperoxygenation during nights for 6 weeks, and we didn't see any improvement in the LV. However, the arch seemed a little bit better, as you are going to see in the measurements here. and the ascending aorta improved a little bit in its z-scores. And you see here the distal transverse arch and the isthmus improved significant from before. So this is the neonatal presentation, and we see the LV it has very good function, and the septum bulges to the right ventricle, and at birth this interator septum was closed. You see the function here, you see all z-scores are below normal sizes, and the arch here, there was antegrade flow across the arch, and the interator septum was closed, as I mentioned before, and you see the z-scores of the aortic arch were not bad. This is the angio-CT scan, and the decision was to proceed with a hybrid procedure, and baby had persistent pulmonary edema, was very difficult to wean off from oxygen, and he had runs of ventricular rhythm, and we decided to open the ASD, as you see here. So, and we can see how the interatrial flow matters a lot in the size of the ventricle. So after septotomy, how small is the LV, and then we proceed, and we stayed in a univentricular circulation for this baby. So possible neonatal outcomes for left heart disease, we can go from univentricular to biventricular, and initial univentricular plus rehabilitation strategies and mildly restrictive ASD. Marcel is going to talk about that. And we, in the neonatal period, we have to look at all these echocardiographic parameters, long axis of LV, RV, mitral and aortic valve annulus diameters, systolic and diastolic function of the LV, of course, EAV grade and distribution, ascending aorta diameter, and aortic arch flow direction. There are many mathematical models developed to predict biventricular repair. This was developed for critical aortic stenosis. I'm not going to talk about them because they are in the web, so it's possible to access. So Rhodes score, CHSS 1, 2, and the others, and all the measurements that have to be obtained, and just put the numbers then, and you can have the chances of success in biventricular circulation. These are the studies, and this is the cutoffs of these different scores to predict risk factors for bad outcome or not suitable for biventricular repair, and etc. So in aortic valvuloplasty borderline LV, my final comments will be: get all possible metric, anatomic, and functional information before considering intervention, fetal intervention. But there is no specific algorithm to predict biventricular circulation when LV is borderline or already hypoplastic after fetal aortic valvuloplasty. Procedure should be performed only when aortic valvuloplasty-related mortality is low, so in an experienced group. And neonatal biventricular circulation might not be considered in the subset of fetuses with critical AS. It's better to go for a staged process. Regarding maternal hyperoxygenation borderline LV, although still under investigation, may be a therapeutic tool for fetuses with borderline LV with no aortic valve obstruction, and it can be used after a successful fetal aortic valvuloplasty. And the management for this kind of ventricles, what I would suggest, get all possible information before deciding the best track for each patient. Varies from patient to patient. Consider experience of the center, of course, intervention, surgery, and the ICU group, and the hybrid procedure may be a good option to postpone the decision beyond the neonatal period. And with that, I finish my presentation. I'm happy to answer any question if they they show
Thank
up.
you so much, Simone. Very important topic, and you covered quite a lot of information. I'll start the questions with Norman. Do you have any comments?
Well, yeah, I do. Firstly, congratulations, Simone, on a wonderful presentation and a great new experience.
Thank you.
My biggest problem was actually differentiating some of these patients that you consider borderline, which I would, with my previous experience, would have considered already hyperplastic left heart syndromes. And then the question is, have you got any features that will tell you, for example, endocardial fibroelastosis, thick endocardial fibroelastosis that prevents the ventricle from growing and developing after you do a valvuloplasty in some of these patients?
Yes.
Second question, I'll let you answer that and I'll answer some other questions later.
Okay, so thank you, Dr. Dr. Silverman, for the question and for the comments. And I agree with you. So it's so hard to differentiate which LV is already hypoplastic for those borderline. And you know, when the aortic valve is closed and very stenotic, the ventricle is very globular and very filled. And when you decompress the left ventricle, you see how hypoplastic it really is. So I think the measurements help, but not that much. And the appearance of the ventricle, I think it's very important. So the very globular ventricles and very diffuse EFE, those, when you decompress, they really get very hypoplastic. I was surprised with the third case that I presented. We were very surprised, but I think that case showed us that sphericity index is very important. So it was not very globular, and the EFE grade was not that bad, although the ventricle was already hypoplastic. So I think the major thing is EFE and how it compromised the LV, the mitral valve apparatus, and all of this.
Simone, before we proceed, for the sake of our audience and all of us, what is the definition of borderline LV? Now, you put numbers, you put RV to LV ratios, you put sphericity index. What is it? What, because then we have to agree what is a borderline in numbers or in criteria.
Yeah, it's hard to get a very nice definition, but I would say that it's not a hypoplastic LV yet, but it's not a normal LV, and it's between
apex forming or non-apex forming.
Not apex forming. So and when the LV is so damaged by EFE, it gets so globular and it seems so big. But if you look at the very apex of the ventricle of the heart, you can see that the apex is formed by the right ventricle, which is, you know, contracting there. So, but I'm very, I have to tell you that it takes time to this definition and to really realize which ones are hypoplastic, which ones are borderline. So the borderline is between both, but it's not an apex formation.
What about the RV to LV? From what you presented, I felt that the ratio is very important, and the sphericity index is important, and the EFE is important. So
Yes.
Which ones do you have it? Do you take everything, or just eyeballing? Okay, as Dr. Silverman said, what you said is borderline. I would call it hypoplastic, and that's really dangerous. We have to follow criteria rather than our subjective impressions.
Yeah, so we have to take measurements, and of course, all the LV structures, mitral valve, aortic valve, in the long axis, the short axis, and everything. And the ratio, as we saw, especially the Linz group published, it's not for borderline LV, it's for after aortic valvuloplasty, which ones will be biventricular. So for them, of course, the LV long exit, so being not hypoplastic before the procedure, it's a marker of biventricular repair after birth. But I think EFE and sphericity index are those very important. So I get all of them, Brima. I measure everything.
The number
But,
the LINS people put for the ratio is 1.5. Is this?
No. 1.5 is very hypoplastic, Aurora.
Almost 1.09, I think, was the number that you had there.
Yeah, so 1.09. This is the number that the group from LINS put. They found that. So it's very close to normal ratio, very close to 1. Okay. So but this is predictor of biventricular circulation after fetal aortic valvuloplasty. This is not borderline LV. Okay, so I had to show you a little bit of what's a borderline LV and the literature related to aortic valvuloplasty, because this is one of the major things that you can do to this kind of hearts during fetal life.
Yeah. Well, I've got a long-term question here. See, I remember Pedro Del Nido saying that he thinks that sometimes a good single ventricle repair is better than a bad two ventricle repair. And I think this is one of the questions that still remains unanswered, because the long-term effects of a two ventricle repair in some of these patients is very poor. The left ventricle is fibrotic, the mitral valve is abnormal, and the diastolic performance of the ventricle is poor. And so you put these kids down this pathway for the rest of their lives. And what we really need to know is like the 10 or the 20-year long-term survival from this, which we don't have this data yet. But it would seem to me that this still remains the question, and of course it's a dilemma that becomes almost impossible to sort out on a single patient basis. The thing, of course, is that of course, what is the repair? I know that you can remove the endocardial fibrosis surgically. Dr. Del Nido and Dr. Frank Hanley at Stanford have done this procedure, and that has certainly relieved some of the diastolic dysfunction, improved the volume of the ventricle, and even with the same ejection fraction, the volume of flow out the aorta is improved. But these patients are already crippled by their disease, their fetal disease. And this is really the real dilemma that we have to sort out, which I'm sure your Dr. Pedro, the other Pedro, and Dr. Jaten will attempt to answer.
Yeah.
So maybe I think that this question, which is the big question mark about this group of patients, should be answered later on in this procedure. But it certainly is a bother for me when I look at this group of patients. And the one question that I think is important, Simone, is that to analyze the failures, because there are a substantial number of failures in this group. I'm not criticizing you for doing it, but the question is there some information that we can have about the failures that would allow us to say, well, this is an inappropriate pathway for these patients, and better that they get a good one ventricle repair?
Yeah. May I answer that?
Yeah, sure. But just I want to add one more thing. Simone already said staged repair. She put this in her she's in 4-stage repair. And also nowadays they do the single ventricle and they can revert it to biventricular. So let's not stress the babies from day one, right? Yes, Simone,
Yes.
sorry.
That's
Yes, no,
also
I agree with Dr. Silverman that this is the great dilemma, and the problem regarding the LV performance in the long term concerns everyone. It's not a normal LV. And I've been following these kids, and I've seen terrible outcomes and excellent outcomes. We know, everybody knows that we now in pediatric cardiology, we are trying to do biventricular repair as many as possible because of our frustrating results of univentricular pathways and all the complications in the late Fontan group. And if we don't investigate, we will never know. So I think we have to work on that. And of course, I have lots of concerns regarding the diastolic dysfunction of this group. And one thing here in Brazil, Dr. Silverman, for hypoplastic left heart syndrome, we still have problems with Norwoods. We are getting better. So sometimes they do better with not excellent LV than a Norwood procedure and things like this. So we had to explore this possibility, and we had the chance, and we do a procedure in a safe way for the mother. And I think we've saved some babies with this disease, and let's see for the long term. I agree with you. This is a concern.
Yes, I think that you make very important points about the long-term results. And I would like to quote Dr. Gil Winofsky here, because he's on the board of the Congenital Heart Academy. And when looking at the hyperplastic left heart syndrome, and let's just keep that as a group, he said that at 10 to 15 years, only 50% of them are still alive. So there is really an attrition in this group, and there's probably an attrition in this borderline left ventricle group as well. The question is it any different? And I think we're going to have to wait for those long-term results. And people like you and Carlos over there, good morning, Carlos, who are doing this will give us the opportunity as a vanguard to see what the results will be. There's Dr. Anita Moon-Grady, with whom I work, is collecting a registry of these patients and how they're doing. And, it's a grim group that we have to deal with. And that's our lot as physicians, as pediatric cardiologists and fetal cardiologists. And I think that, the decisions that can be made, including termination of pregnancy, are something that are really come down in the fetal area to be the most critical and important decisions in the long-term history of this disease.
I just wondered, we have one question from the audience, and I think it's well said regarding the maternal hyperoxygenation test. Now there is, as you said, diagnostic and a sort of prognostic tool. Tell us more. She's asking for the protocol for the diagnostic one, and for the Anna is asking for the diagnostic and the treatment protocol that you had.
Okay. So for the diagnostic tool, and I use mainly for the aneurysm, interator septal aneurysm and borderline LV, and it can be used for transposition of the great arteries to see if the foramen ovale will be restricted. And so you do your study and start with maternal hyperoxygenation. I use the catheter and about 60% of FI, oxygen, and for 10 minutes. And after 10 minutes, which is the steady state of the use of it, you start looking at the heart. So what you see, you have to get the pulmonary vein Doppler before and after and see if there is an increase in the VTI of this flow. You can check the pulmonary valve, pulmonary artery flow and VTI, and check if there is increase after that, after the maternal hyperoxygenation. This means that there is pulmonary reactivity, okay? And when you have the aneurysm, the septal aneurysm, as you saw there, you see how it bulges from the left to the right because the pulmonary vein Doppler flow is increased. And this may increase the LV filling and the antegrade flow to the aorta, aortic arch. And we may say that it can improve the oxygen for the cerebral. Okay, to the head. And for the chronic, you may use, it's so hard to do that during the day. So once I put the patient in hospital for 3 times, and I did 18 hours a day with some stops, and she was in hospital, but it's very difficult when you are healthy and not, the problem is with the baby. So I don't do that much. I tried sometimes. We propose to do that at night, during night, and spend all the night with a mask or a catheter to receive this oxygen.
So it's 60% nasal cannula, FiO2 for 10 minutes for the test and for 8 to 12 hours for the treatment. And for how many days?
If you can do 4 weeks, more or less, about
so every day at night for 4 weeks. And then you will measure, and then you look at the flow of the pulmonary vein and pulmonary artery, and there is increased flow, decreased pulmonary vascular resistance. And then you look also at the antegrade flow of the aorta. I think you showed some.
You can do the VTI of the aorta. You can see the mitral flow. You can measure the diameters pre and post. But the main parameters to show that there is pulmonary reactivity and this baby will respond to that is the pulmonary vein Doppler. And you will just measure the VTI and see how it increases after the hyperoxygenation. The chronic one, of course, you may measure the structures and put in the Z-scores and see if the structures are growing.
So you expect the flow to increase from the LA to LV to aorta, right?
Right.
Okay. And then the bulge in the septum will decrease with time, right? In the septum should decrease with time.
With the interatrial aneurysm, this is a benign disease. This is just diagnostic. You don't have to do that chronically, okay? It just says that, oh, wow. This left atrium, left ventricle, they are in good size. They are just not feeling very well because of the interatrial aneurysm. And when the baby is born, because of the lung perfusion, left atrial pressures increase, and the septum is bulged to the other side, and then the heart is feeling better. Sometimes they can have a little bit of pulmonary edema, but it's just like a transient tachypnea or something like this.
Thank you so much. And of course, the maternal hyperoxygenation test has non-cardiac uses as well, antenatally, not just cardiac diseases. So I'd like to thank Simone for a beautiful presentation, and really lots of question marks that needs to be answered with time. And I'll also think Dr. Silverman's comment about the query use of the antenatal intervention in utero to trying to push from unit to biventricular repair. I think this has been the question for the past 10 years or so. and since the Boston, or maybe 15 since the Boston group started. Our next speaker is Carlos Pedra. And thank you so much, Carlos. I know that there was a bit of technical issues with the timing. Thank you for coming. And Carlos is, of course, the head of Cath Lab at the San Paulo Hospital, working together with Simone Pedra in the same place. Thank you.
Thank you, Rima. Hi, Norman.
Hi, Carlos.
Yeah, it's a pleasure to be here. I'm honored to be here. Thanks, Grace and Rima and you and all the people who are involved in the organization of these marvelous events. So I'm going to share my screen. We did have some technical issues, but I think we're going to do fine. So let me see. Can you see the screen here?
Yeah, I can see the screen, but sort of put it in the mode of the PowerPoint. Thank you.
Yeah, now it's good, right? Yeah.
Yes, thank you. Beautiful. Thank you so much.
So, okay, so let's tackle this difficult topic, borderline ventricle, and see what catheterization can help in the management of such patients. Let me see if I can go further here. Yeah, I do not have any conflicts of interests for this presentation, although I'm a proctor for a couple of devices in interventional cardiology. And usually those borderlines LV are usually associated with critical AS or critical coarctation. As you saw, the diagnosis can be made in utero. When there is aortic stenosis, I think it's easier to define what a borderline is. That it's not that easy when you're dealing with coarctation. Everybody knows that intrautero diagnosis of coarctation is not that easy. And of course, we've been discussing some pitfalls and the definition of a borderline left ventricle. You've seen how Simone defined that on echo. I'm not going to go there. MRI can be used for older infants and children. And at some point, those patients will need a catheterization. And of course, we've been discussing that in the last maybe 10, 20 minutes, that size, sometimes the ventricle is good, but the function, especially the diastolic function, can be terrible. And usually these patients are very difficult to deal. So our concept is that we really push the envelope to rehabilitate those ventricles in a stage process. We don't have to hurry. I mean, we're not supposed to define if this patient is going to a uni or a biventricular pathway in the neonatal period, not even before births. So we think that their rehabilitation, the sooner we start, the better. These patients goes through a neonatal breach as a hybrid procedure, and biventricular repair, if it's possible, is achieved at the end of the first year of life. And you're going to see these patients will need sometimes many caths. And after biventricular repair, these patients, we have to keep an eye on that because of possible diastolic dysfunction of the left ventricle, and catheterization is also possible. So, and you know, a quick point here that, of course, hybrid is not only do bending and putting a stand, in fact, involves many people in the ICU, imaging, and a whole concept that is dealt with in an institution. So starting with the hybrid, quotation marks, in utero, fetal valvuloplasty, I think Simone has gone over this topic. When you have aortic stenosis, moderate to severe LV systolic dysfunction, when there is retrograde aortic arch flow, abnormal flow across the interatrial septum, abnormal flow across the mitral valve. We talked about sphericity index. When there's lots of EFE, as you can see here, these patients, the likelihood of developing hypoplasties is very high. So we intervene in those patients. This is old data. I think Simone had shown more updated data here, but we are reaching almost 100 procedures in fetal aortic stenosis, as you can see here. Usually these patients arrive to us at a later gestational age, which is easier from the technical standpoint. It makes the procedure easier. However, the outcomes may not be optimal. So this is the best scenario when these patients undergo the procedure. This is the pictures of the fetal life at 20 weeks of gestation, and this is 30 weeks of gestations. You can see an improvement of LV size and function, and this patient didn't have to undergo anything in the neonatal period. This is the appearance of the patient at 3 years of age. So this is not that common. However, you do find patients like that. Sometimes you need to do an repeat aortic valvuloplasty in the neonatal period. So this is a case which exemplifies a stage rehabilitation. This patient was in fetal hydrops, had critical AS, had severe MR. So we open up the valve. He had to undergo emergency neonatal atrial septostomy, and we did a hybrid. You can see the ventricle before the procedure and after we did a hybrid. You can see it's not totally normal. You can see the ASD here, but you don't have to hurry, right? You did your hybrid. We know, of course, that an orbit can be done, and then you reverse to biventricular repair. The Boston group does that. As Simone said, we'd rather go for a hybrid procedure. It works better in your hands. I think it's simpler, right? And of course, neonatal interventions, these patients undergo hybrid, PA, pulmonary bending, PDA stenting, and of course we do atrial septostomy. When you are dealing with true, very well established hypoplastic left ventricle, you open up the septum and create an ASD as big as possible, right? But when you're dealing with borderline left ventricles, it's kind of tricky. You have to open up the septum, but not that much, right? You have to leave like an ASD measuring around 4. Otherwise, if you open up the septum totally, you won't get flow across the mitral valve, and you won't have any stimulus for this left ventricle to grow. So this is a quick picture of a patient who underwent bending and a stent in the PDA, nothing really fancy. And then for these patients, you bring them back to open up the septum, because if you don't open the septum, on the other hand, they'll get pulmonary edema and pulmonary hypertension, which will be bad in the future. So we enter the septum, we put a little balloon, we increase the size of the balloon, we do atrial septostomy with a Z5 balloon, usually 5 French, to open up the septum, but not that much. So you sort of can titrate the size of the interatrial communication that you want to create, leaving a bit of gradient across the interatrial septum. This is a very busy slide. I think Simone has gone over our data. In summary, sorry, this is in Portuguese because I presented in a local meeting. We had, when we do aortic valvuloplasty in neutral, we have according to the intention to treat, 50% mortality. I'm not saying in neutral. I'm taking into account the kids that die in neutral and after birth as well. On the other hand, 2/3 of our surviving patients, they had biventricular repair. Half of them undergoing hybrid procedure and half of them undergoing valvuloplasty only. In neutral or repeat valvuloplasty in neonatal period. And of course, we talked about hybrid and weight, and let the patient tell us what we should do at the end of the first year of life. But this interstage period can be also tricky, and catheterization does have a role here. Sometimes these patients get more cyanosed, of course, because they outgrow the size of the banding, not the size, but how tight it is. And sometimes they have to, we have to redo an ASD intervention. When you put stents in the PDA, you can have retrograde aortic obstruction, but this is not a problem in such patients, right? Because you have antegrade flow across the aortic valve. So usually we tackle the bands. This is a patient that had a very tight right PA band, and then we open up the band a little bit so it can increase pulmonary flow, increase the saturation. Again, another example of dilatation of the left PA band, right? You can see here that the stent is nicely placed. There's no neointimal proliferation. We also take a look at the LV diastolic function, if there's grading across the aortic valve, etc. Of course, we do complete catheterization study. So even if these patients do well, of course, before biventricular repair, if the LV is considered good size, we bring them to the cath laboratory. We take pressures everywhere, descending aorta, ascending aorta, left ventricle. We take pictures. We try to profile the stent. Look how this ventricle, left ventricle, is not that contractile. It does have some EFE. We place a lot of importance in the left and diastolic pressure. We consider it's okay to undergo biventricular repair with diastolic pressures up to 12, 14. More than that can be very tricky in the post-operatory period. And of course, we collect the pulmonary vein pressure, which will be the pulmonary pressure beyond the banding. You can also take those pressures using coronary wires, but they are expensive. So we enter the ASD, we enter the veins, and we took the wedged pressure. Now, of course, we go across the aortic valve. And it's interesting because most of patients, they have complete antegrade flow across the arch, not only ascending aorta, but the arch. And then the PDA does the job to provide adequate flow to the lower part of the body. So when these kids are considered to be okay for a biventricular repair, at, let's say, 9 months, 12 months, let them tell us what to do, then we do some sort of hybrid takedown. Of course, as Norma mentioned, this was introduced by the Boston group, but in our center, Marcelo does a wonderful job to resect the EFE. He also works on some valvuloplasty, does some leaflet thinning. We, of course, leave a residual ASD as a pop-off valve. This is very important. And sometimes these patients needs ROS, some work on the mitral valve. I think mitral valve disease, it can be a very limiting, very bad limiting factor for such patients. And after these kids come off bypass, we do an exit angio, and if the pulmonary arteries don't look well, then we put stents. So this is some pictures of catheterization before biventricular repair. This is the aspect of the pulmonary arteries. This is the aspect of the left ventricle. We do see here that the left ventricle is not totally normal when it comes to size, but it does provide a beautiful antegrade flow across the aortic valve and across the arch. Of course, we take pressure measurements. Of course, they undergo MRI study to assess the volume of the left ventricle. So this patient had good LV volume, and Marcelo did some work to resect the EFE, as you can see here. And this we do, of course, TE after biventricular repair, and look how beautiful this left ventricle is, and this aortic valve after some work of leaflet thinning and so forth. And here on the left panel, we can see the ASD shunting left to right. So this is another example of final outcome, that patient that underwent emergent atrial septostomy. This was the aspect at 1 month of age, and this is the aspect at 2 years of age. So very, very encouraging. And this patient had severe mitral regurgitation, which increased with time. A couple of pictures to show that after biventricular repair in the OR, we have a nice hybrid room. We take some pictures at the pulmonary arteries, and when we see those stenosis, it's really quite easy, not a big deal to just put a sheath in and put a stent on the left side, on the right side. So sometimes Marcelo doesn't even touch the pulmonary arteries to avoid injury to the phrenic nerve. So just the quick angio, and if the PAs look bad, we go ahead and put some stents. And as I alluded to, serial assessment of the left ventricle is very important after biventricular repair. These patients can get bad pulmonary hypertension because of LV diastolic dysfunction, and some of them are candidates for transplantation. Some examples of 2 cases late after biventricular repair, after hybrid. This patient was 13 months. He had a biventricular repair at 8-9 months, more or less. There was some concern about how big the SD is, although the gradient across the SD by echo was 7. So we took him to the cath lab. These are the pressures, very high RA pressure. When I took the pressure, it doesn't look good. Very high RV pressure. And look how high the diastolic pressure in the PA was. And in line with the wedge pressure, in line with the pressure in the left atrium, in line with the left end diastolic pressure here, and not much of a gradient across the aortic valve, and not much of a gradient across the arch. This patient had some coarctation too. And you can see here the appearance of the left ventricle. It does contract well. The problem is not systolic function, it's the diastolic function. This was the ASD shunting left to right. It didn't seem to us that the ASD was too big, right? It was appropriate size. You can see the gradient here across the ASD. So what we did here, and we do think this is very important, is to do a test balloon occlusion of the ASD and see how the left ventricle responds to that, it behaves. And in this patient, the LVEDP increased from 25 to 40 after ASD occlusion. In other words, almost no coronary perfusion, right? So it's because of diastolic dysfunction. And we can see here the Doppler pattern of the pulmonary veins pre and post, striking worsening, and this also happened with the Doppler pattern across the mitral valve pre-closure and after closure with reversal PA wave, right? And the RV systolic pressure by echo increased from 50 to over 80 after ASD closure. So we left this ASD alone. In fact, this patient came back, coarctation got worse with time, and we put a little stent in the coarctation through the carotid artery, and hopefully this diastolic LV pressure will improve with time. So we are caught between a rock and a hard place. No SD results in pulmonary venous edema, but sometimes too large an SD may cause torrential pulmonary flow and congestive heart failure. So sometimes we can close those SD, but not completely. We partially closed, and we use a custom-made fenestrated device. I know in Europe, a manufactured device, fenestrated device, is available from Ocultech. Unfortunately, we don't have access to this technology here in Brazil, so we have to improvise and be creative in the cath lab to solve this problem. So this was too large an ASD, resulting in high pulmonary blood flow due to diastolic dysfunction. We did an occlusion test with the balloon with not much of a change of the pulmonary vein Doppler, of the mitral valve Doppler. As you can see here, pre and post, almost the same aspect. So we went ahead and we put a fenestrated device. How we do that? We perk the wire mesh of the device with a needle, and we place a very large bore sheath, create a fenestration. We leave a wire through it, and we implant the device with the wire across the fenestration. And this wire allows you to navigate a little coronary stent across that hole that had been created by the sheath. And then we put this little coronary stent creating, let's say, 5 millimeters ASD. We do use drug-eluting stents for that. And this is the appearance of the custom created device with that fenestration. The fenestration seen on FAS here, both on echo and on angio as well. So in conclusion, I think catheterization, especially, of course, interventional cardiology has a pivotal role to rehabilitate those dysfunctions / borderline left ventricles in many periods of life, as you saw. Diagnostic catheterization is crucial to assess hemodynamics before any attempt of biventricular repair. We put a lot of emphasis on an adequate size of ST, both pre and post biventricular, both pre and post biventricular repair. And we should keep an eye on those patients. And whenever they are not doing well, we bring them back for late assessment in the cath lab and see how the SD is doing. Take a look at the left diastolic pressure, left end diastolic pressure, and also in the pulmonary arteries. So with that, I conclude. I thank you so much for the opportunity of sharing our experience in such a tough topic.
Thank you so much, Carlos. Beautiful. Now, just wanted, before we move to our last speaker, but not least, now, what is a borderline LV to you, Carlos, as an intervention cardiologist? When you look at it, what is it? What numbers you are focusing at?
Yeah, it's, you know what, I think we used to talk about that a lot when we were in Toronto, talked to Lee and Bob and David Nickney. Sometimes your eyeballing works better than your measurements, right? Because everybody knows that, you know, those measurements can have like inter variability a lot. You can get what you want, right? And we are dealing with Z values, blah, blah, blah. So I think, I mean, well, if I take a look at this ventricle, it's very subjective, I must admit. So I don't do all those plottings of volume. I don't do.
But at least you look at it's apex forming, non-apex forming.
Yeah,
there's
apex
AV, there's no AV.
I think MRI is better than cath for that. And when you see the left ventricle, the contractile function, right? It works well, the systolic, but it's like when it relaxes, it's like being in that kind of thing that the policeman takes you today, Jay, you know, it's like.
But still, I want to corner you more. Give me two measurements that you really care, or three, before you decide you take the patient to.
I think Z-value of the left ventricle, I think based on echo, we use all those things, ratio mitral valve, LVOT, the Z-value of the aortic valve, the length of the left ventricle. Of course, I think we place lots of importance in physiologic data, such as LV and diastolic pressure, and volumes on MRI. So over 25, 30, I think it's okay to undergo cc's per meter square. I'm talking about. It's okay to undergo biventricular repair. So it's like a puzzle. All the pieces must fit. So it's not.
So bottom line, you take more than one reading. You take the clinical. You take the weight of the baby. Yeah, and then because we have also maternal fetal specialists with us. So what is a hybrid?
Oh, what's a hybrid? That's a very good question. Sorry if I was not clear, right? A hybrid is, we take these patients to either a hybrid room or a regular OR, and we can do that with a fancy hybrid room or with a C-arm in the OR. Surgeon places bands in the pulmonary arteries, and we leave a sheath in the main pulmonary artery, and across that sheath, we put a stent in the PDA. So we create a physiology that it's equal to the fetal physiology, right? We make the RV work as the main chamber to provide adequate cardiac put, especially to the lower part of the body, because the left ventricle, the aortic valve is open. The left ventricle can take care of the flow to the AC, the aorta, and the head and neck vessels. So that's what we do with the hybrid. And after maybe a median time of 20 days, in those patients with borderline left ventricles, we open up the septum. So when you have established hypoplastic left ventricle syndrome, we open totally the ASD. When you have borderline ventricles, we leave an ASD measuring, let's say, 4 or 5 millimeters with some gradient across the SD. And this is as I said, the reason is to make the LV work and grow, because if it doesn't get any flow, it won't shrink if you open up the SD completely.
So bottom line, hybrid is a procedure that it's two things. Hybrid is a mixture of two things, surgery and cath. And in this case, exactly. You take the babies, and usually if the baby is not, in many centers, not fit for surgery, a lot of surgeons prefer, like if it's 2 kilos or 1.8 or 2.2, they take them for a hybrid where they try as much as possible to keep the duct open, to perfuse the body, and also to obstruct the right and left pulmonary arteries with bands, so that to create a sort of a borderline or a better flow physiology for the newborn. And then you mentioned a beautiful point about the ASD. Make it small, make it big, open it. That's very important, where you think that borderline means leave an average ASD, hypoplast, do a big ASD. Is this correct? Bottom line of this?
Yeah, totally correct. We know that probably most centers in the US use hybrid in high-risk patients, syndromic patients, low birth weight and comorbidities, etc. We don't have this approach here. We accept all comers, right? Because in our hands, the hybrid works much better than a neonatal Norwoods, let's say. For borderlines left ventricle, the Boston group they go for Norwoods, and they can change their minds and reverse to a biventricular repair at the end of infancy. I think that's that's reasonable. But in our hands, we do differently. We, we had mentors such as Dietmar Stranz and John Sheehan in Columbus, and we were heavily influenced by them. And then things started to work in a much better way when we shifted to hybrid in 2005 and 7, more or less. And I think Marcelo will talk about that. When Marcelo embraced the hybrid concept, then things started to get better. So that's why everybody has to be in the same page inside this hybrid concept. It's not only interventional cardiology and surgery. It's something that involves everybody.
Thank you. Norman, you want to ask a question?
Yes, I did. First of all, I want to congratulate you, Carlos, on a superb presentation. The second issue that I wanted to talk about is the relationship of cardiac transplantation. I mean, that's always sitting on one's mind when you look at this group of patients with their blighted left ventricles. And I mean that because we know that they are, as you show, fibrotic, they don't contract well, they have high end-diastolic pressure. And I think that when one considers this whole perspective, it's also a question of when is it an appropriate time to consider cardiac transplantation. And this, of course, is going to vary as well as you talk about the hybrids from country to country. So what is your approach to cardiac transplantation when you throw in the towel and say, let's do a heart transplant?
That's an excellent question. We did have some patients that underwent cardiac transplantation. And I think if the right ventricle is working reasonably against an increased pulmonary vascular resistance, right? Because this is post-capillary pulmonary hypertension. So if the RV is working reasonably well and we keep an eye on that, we try to postpone. Why? Because of the availability of heart donors, right? At a younger age, which is tough. So probably we had, I'm not sure, I think Simone knows better than me. She has the data. I think we had maybe 2 or 3 patients that underwent transplantation at the age between 3 and 6. I can remember well. But as long as the RVs are working reasonably well, we try to postpone, right? We talk to the family, and I think this is what would be our north. I'm not sure if Simone wants to say something or Marcelo in this regard.
Well, yeah, that's a very interesting point. I must say that the one thing about the hybrid that Frank Hanley has always talked to me about is just as in Boston, we prefer to do a Norwood procedure to a hybrid procedure. And one of the things that Dr. Hanley always mentions, he says, yes, well, the morbidity and mortality may be lower when you do a hybrid procedure, but then the correction of a hybrid procedure has a much higher percentage than a staged Norwood procedure in the end, the second procedure for a hybrid. So I don't think that that's a problem. I think that you do what is best in your country, but I do think that there are other alternatives.
Yeah, well, Mark Alantovics has a different attitude, right? It's not a problem to, do a biventricular repair after a hybrid. I know it's a very big surgery. I do agree, to correct the arch, to the PAs, and do all the EFE resection, valves. Sometimes you have to work on the mitral valve. But it's doable, I think both pathways are reasonable. Depends on what you're familiar. Do what you do best. That it's the bottom line. That's
correct. That's fine.
Yeah.
Let me ask you just a question about the mitral valve. When we looked at the Rhodes criteria, for example, we found that the bottom line about whether you could do one thing or another related to the mitral valve size. Is that something that you measure or are concerned about?
Yeah, of course, yeah. Z-score and the ratio. I think, Norman, correct me if I'm wrong, because you don't know what's going to happen. We always try to give it a go. That's why we push the envelope to try to rehabilitate those ventricles, and that's why we place a lot of importance in the size of the ASD. So as long as you have an restricted ASD, the mitral valve size can improve the Z value. So we don't make the decision in the neonatal period. So just wait. But of course, sometimes it does not improve, bad values lower than minus 2.5, whatever. Okay, the kid is not undergoing biventricular repair. But I think the worst scenario is when you have subvalvular disease or like those shortened chordae, parachute. I think these are terrible mitral valves, terrible. And you don't have that many options surgically, right? Because plasty of those valves, it's very tough. It's very tough. And if you have to do mitral valve replacement, we've been there. Sometimes we use an aortic valve the other way around, upside down, put in the mitral valve. It's also, in 6 months, it gets calcified. It doesn't work. I think you do. So again, I think that's why we do hybrid, leave a small SD, borderline mitral valve LV, whatever. And let's see, let the patient tell us what he wants in his or her life, whatever.
Oh, good. Very, very well handled question, that. And somebody had asked the question in the question and answer about anticoagulation, about thrombosis in the vessels. Do you have any specific anticoagulation protocol that you use?
No, we keep those patients under aspirin, small doses, 3 to 5 milligrams per kilo. But, I've never seen a stent in the PDA get thrombosed. This doesn't happen.
I asked that on behalf of one of the questions in the question and answer chat.
Yeah, we do see neointimal proliferation, and sometimes you can miss the ductal tissue during state placement, either proximally or distally. So that's why we tend to use longer balloon expandable stents to cover the whole ductal tissue. This is from the technical standpoint is crucial. It's the tip that I could recommend.
But then the question, Dr. Silverman, the question is asked by using aspirin and Plavix. So do you use both? And
no, just aspirin.
Just aspirin. So like any stent, it's like any PDA stent, right? Yeah. And you use it for how long after?
The thing is, this is a big PDA stent, right? For preemies, for instance.
Okay, so you want to continue till surgery.
Yeah, and for larger neonates, it's like 8, 9, 10. So, and the amount of flow is huge, right? Because the right ventricle is providing the cardiac output for the lower part of the body. So that's why it doesn't get thrombosis. There's no way there would be thrombosis there. So this is different than when you have right-sided disease, that you want to put a PDA stent to provide pulmonary blood flow. Then we put drug-eluted stents, coronary stents, and keep the patients on both aspirin and clopidogrel. That's different. That's totally different.
Thank you. It's beautiful.
So I just want to make one quick point, Rima, and that is that other famous Brazilian, Dr. Da Silva, who's working on the right side, is showing the same sort of issues as you show, that when you do an operation on a ventricle, the molding that can occur after that operation, whether it's a right or a left ventricle, can occur, and you can't just judge the event by something that happens immediately, but there is molding and development that occurs both on the left and the right side.
Totally agree. We've seen, talking about Epstein disease, for instance, right, with the cone procedure, and Dr. Da Silva is an amazing guy, came up with this kind of repair. And when you operate, those kids get really worse in the post-operative period. It's amazing. Oh. The right ventricle function goes down, right? Yeah. You have to leave an ASD as a pop-off valve. They get cyanosis, but the cardiac output is okay. But with time, you bring those patients back after 6 months, whatever, and the RV is contracting. It's amazing. So how they can remodel with time. That's why, that's why I think we always have to keep that thing in mind. Let's give this a chance. Let's give this a chance.
Right. And of course, the other thing that Da Silva is doing now is looking at pulmonary atresia and doing an operation to improve the right ventricle by taking care of some of the muscle and the endocardial fibrosis, etc. And the ventricles continue to grow, just as you would do if you were doing a hybrid procedure. So the physiology is changing because the anatomy is different.
Yeah, well, I think Marcelo will address that in surgical options. I think the Boston group, again, they came up with this inverted 1.5 ventricle repair, right? Leave the RV to take care of the systemic circulation and the LV to take care of the pulmonary situation, right? Doing a switch and a sending. This is too big an operation. We don't have any experience with that. Right. And I wonder how the long-term results will be. Very interesting.
Okay, thank you so much. Beautiful discussion.
You're welcome, Rima. Great honor.
Our last but not least speaker is Dr. Marcelo Jetin. He's the son of the famous Dr. Adib Jetin, the ASO, the very famous, well-known surgeon in the whole world. And he's the associate professor of the cardiovascular surgery medical school and University of Sao Paulo. And he's also the director of pediatric cardiology surgery at Unit Institute I cannot pronounce the name, I'm sorry, Corso, in Incor. And thank you so much for joining us, and thank you for sparing your time. We know surgeons are always very busy, but we're very happy to learn from you. You can share your screen, Marcelo, if you like.
Yes. Thank you very much, Rima. And thank you, Dr. Silverman, for the invitation and the possibility to be here. And let me finish is everything okay?
Yes, please go ahead. Yes.
Okay, thank you. I'm just trying to put over here. Okay. So I want to thank the Heart Academy, the Congenital Heart Academy, for the invitation. And it's a huge pleasure to be together with Timoni and Kaká, that we are working together in this very challenging situation for many years. And we having the opportunity to discuss all these details is I think it's very important for us. Before going specifically in the subject, I just want to give me 1 second, please. There are some problems here. There's a lot of things in front of me. I don't know how to take all this off. Give me just 1 second. Now it's okay. So before moving to the presentation, I'd like to make some reflections. So before choosing the best surgical technique, I think we might have conscience that the hypoplastic left heart syndrome and its variants, critical aortic stenosis complexity, you must have disposition to face trouble. And you must have a personal and team emotional control and deal with frustrations, because they are very complex cases that you require sometimes multiple approaches and multiple types of procedures. And you must know your institution and your limits. And you must have a big partnership with the hospital administration because of high cost, length of stay, and comorbidity. Some of these children might remain on hospital since they were born till some month later to the second stage to make the correction. So this is something to be considered. If we consider here the total health expenditure per capita in US dollars, we can see that countries like United States, Norway, Sweden, Switzerland uses more than $4,000 per capita in health expenditures. And for example, United States and Switzerland close to $10,000 per patient. And in the opposite side, countries like African countries like Burkina Faso, Burundi, or even in Asia like Cambodia uses less than $50 for health expenditure per patient. Brazil, close to Chile, we use something around $800 to $1,000 per patient. So this brings us to a situation that we might consider all these aspects to be able to offer the best for the patients. So to treat a borderline left ventricle, it's really a team approach. I always say that the concept of team, in the words of Michael Jordan, the famous basketball player, is that individual talents wins games, but just teamwork wins championships. So this is what we think about all these aspects. Talking about fetal intervention and postnatal surgery, we might consider some cases. For example, critical aortic stenosis, that are most of the cases that Simone and Carlos had shown, with dilated or dysfunctional left ventricle, the hypoplastic left heart syndrome and its variants when we require sometimes the ASD opening, or the borderline left ventricle. The image is very important to decide the treatment just in the fetal period and even after with the echo, CT scan, NMR, and angiography to help you to decide the best treatment for the patient. When we consider, for example, hypoplastic left heart syndrome, we have many surgical options to treat these patients. We can consider even the natural evolution with no surgical, just comfort for the children, or you can interrupt the pregnancy, which is not common in our community, in our countries. But the staged procedures like Norwood or Norwood-Sano and the hybrid procedure, and even the heart transplantation are possible treatments to surgically treat hypoplastic left heart syndrome. Considering the NORD operation, this is publication from the SVR trial, single ventricle reconstruction trial, that is led by Dr. Richard Oy from Michigan. And he considered two different treatments for hypoplastic left heart syndrome: the Norwood operation with the BT shunt and the Norwood operation with the Sano shunt, the right ventricle to pulmonary artery shunt. And we can observe that they are having similar follow-up, similar results. And the transplantation-free survival in both cases is around 60% after 48 months, despite the fact of very good results in the initial or in the intra-hospital stage during the operation. And when you evaluate technical performance scores in this patient's outcome in the Norwood procedure, we can see that the class 3, which is considered an inadequate technical performance score that evaluate the surgery and the surgeons, we can see that there are the number of days of discharge is quite long, and the days of extubation is quite long. So a perfect surgery with a good technical performance score and no residual lesion is quite important to have less time in the post-op and less time in the hospital. When you evaluate the results of this trial, the SVR trial, 6 years, almost 10 years after the beginning of the trial, we can see that the BT shunt and the right ventricle shunt has a similar follow-up, and they are freedom from death or transplant in around 60% of the cases. As I said in the beginning, despite a good result in the beginning, most of the children are having problems and dying or needing a transplant in the course of their follow-up. And this trial only includes the best institutions in the United States with the best results in hypoplastic left heart syndrome. And they are free for catheter intervention, a little better the cases of modified BT shunt than right ventricle pulmonary artery shunt. But there are similar results concerning strokes, concerning the proportion with thrombosis, with seizures, and the proportions with protein-losing enteropathy in the late postoperative. So trying to answer Rima about what is the hybrid procedure for example, for hypoplastic left heart syndrome, and for all the cases we are discussing today, it's a staged operation that consists of the manufacturing of a right and left PA bending, the placement of a PDA stent, and sometimes the ASD opening. This was most described in the beginning of the experience, but not what we are using frequently in in our experience. And it's a procedure with no cardiopulmonary bypass. You might have an sternotomy, and the surgeon and the interventionist works together in the same patient doing this type of surgery. What's the rationale for the hybrid procedure? It's a less invasive initial procedure especially for neonates. You can program the more invasive procedure to an older age with better weight and organ maturity, like between 4 to 6 months. The idea is to try to reduce morbid mortality and to reduce the cumulative impact of repeated interventions. And after this period of time, you must have the most demanding and consuming operation, as Dr. Silverman has said, which is the stage 2, the comprehensive stage 2, what we call the Norwood-Glenn procedure, when we make the reconstruction of the aortic arch, the removal of the bendings, the right and the left PA bending, disconnecting the pulmonary artery from the pulmonary trunk, the connection of the pulmonary artery to the arch and the descending aorta, and then the manufacturing of a Glenn shunt and the opening of the ASD, the atrial septectomy. As Carlos had mentioned, we sometimes have difficult approach to the left pulmonary artery because of scars and adhesions, because of the risk of having problems in the phrenic nerves. We have tried many attempts of procedures, but what we consider the best result and the best solution is the placement of the LPA stenting that we are using. In the beginning, we are using in around 35 to 40% of the cases in our experience. And nowadays, probably most of the cases are receiving a PDA stent because of many of these reasons in the surgery. As I said, it's a consuming operation. It's a very long one that we might reconstruct the arch and do all the other procedures, but it's possible to have results, let's say favorable results, as we can see in the Giesen publication from their experience, that in which they referred to 123 cases of the pulmonary artery bending and ductal stenting, being 154 of hypoplastic left heart syndrome and 69 of hypoplastic left heart complex, where they come or to a biventricular repair after the bending and after the hybrid procedure, and the hypoplastic left heart syndrome goes forward with the staged palliation. So the use of hybrid approach is considered one of the options to prepare and to have more time for the left ventricle to grow, to try to achieve a biventricular repair. Talking about the numbers, considering the 154 cases with the hybrid approach, 7 were maintained in comfort therapy, 8 were primarily listed for heart transplant, and 7 were transplant, and 139 patients went to the staged palliation. And what we can see in the results are that after 15 years, 74% of the patients are alive and well, and excluding the comfort care patients, 78% of the patients are alive and well 15 years after the surgery. This including all the stages, like the first stage with the hybrid procedure, the second comprehensive stage, and the third stage, which is the cavo-pulmonary connection, the Fontan operation, that we are always using the extra cardiac conduct for most of the cases. Also, these are their results for the staged palliation between 15 to 20 years. And this is the primary heart transplant. As soon as the transplant is done, the result is good. And the comfort care patients, most of them died in the first days after delivery. This is resumed a summary of our results in the H-core. Since we began in 2008, we had an initial experience the first 3 years with less than 18% of mortality. So we had a more liberal indication, and our mortality increased a lot. We did our team retraining, a visit to Giessen, and then we came back and are improving slowly our results. So as a summary, we had done more than 200 cases of hybrid procedures in hypoplastic left heart syndrome and hypoplastic left complex, and with a mortality rate around 21.9%. The second stage, the Norwood Glen or the comprehensive stage 2, we had 72 cases with a mortality of 19%. We have done more than 30 cases of Fontans with one death with a 2.8 mortality, which is considered for our, let's say, experience, interesting results. So the other problem is that what is considered as the treatment for hypoplastic left heart syndrome, in our opinion, our initial treatment, as Carlos mentioned, is the hybrid procedure for all cases of hypoplastic left syndromes, excluding some cases with severe hypoplastic arch hypoplasia and severe coarctation with aortic atresia and mitral atresia. In these cases, we consider to perform a Norwood operation. So the borderline left ventricle, talking about the borderline, the postnatal evaluation, we might define the left ventricle size by all the images we can use, and we might define what is being done with the fibroelastosis of the left ventricle. Is it resectable? We might resect or not. And so the hybrid approach comes with an option for maybe a future biventricular repair. So the hybrid approach is not a definitive solution. You can encourage the possibility of left ventricle growth. And one of the reasons, the most important things is to keep a small ASD. And you keep all options and all doors open to try to treat this patient after a hybrid procedure. And sometimes we might follow the univentricular repair track in cases where the hypoplasia of the left ventricle or severe hypertrophy doesn't allow us to go to the biventricular repair, or if the fibroelastosis is impairing the left ventricle systolic and diastolic function. So the surgical strategy that we use in the cases that is possible is as Carlos and Simone had mentioned, the fetal aortic balloon valvuloplastic, then the hybrid approach, then the biventricular repair after image evaluation and or the fibroelastosis resection. We usually touch the aortic and mitral valve during surgery, trying to perform the mitral and aortic valvuloplasties and keep a small ASD. This is a case with 24 weeks with severe fetal hydropsis, and during the atrioventricular, during the aortic valve dilatation. This is 30 days postnatal after the hybrid procedure. Here's the left ventricle in comparisons to the right ventricle, and here's the left ventricle 10 months after the biventricular repair. It grows, and here's the left ventricle much better, and the aortic valve might be touched also. And this is the patient 14 months after the birth. Was 4 months after the biventricular repair with a very good and functional left ventricle repair. Considering the International Fetal Cardiac Intervention Registry, there is a published in the JAC among the live-born infants with a fetal diagnosis of aortic stenosis and evolving hypoplastic left syndrome, more than twice as many were discharged with biventricular circulation after successful fetal cardiac intervention versus those meeting institutional criteria but without any successful fetal intervention. When fetal death were counted as treatment failures, the percentage was similar. Biventricular circulation at discharge, 31 versus 18% for those discharged with univentricular repair. This is a movie just to see left ventricle apex approach to resect the fibroelastosis. This is always a concern that we have, how much we touch, how much we must be invasive to open the left ventricle and to try to resect, sometimes using the aortic valve. And this is the resection of a huge membrane of intervention. And then we are respecting the mitral valve, and we are respecting the septum. And here is the fibroelastosis of this patient. And especially in this patient, the results are good. The left ventricle is with a good function and no problems yet, even with the scar in the left ventricle apex. There are other approaches to these kinds of borderline ventricles, like the Boston Children's view and procedure. This is the postnatal outcomes for the first 100 patients. They are using this procedure. They attempt fetal aortic valvuloplasties in the 100 patients. So you had termination of pregnancy or fetal dismiss in 12, live-born patients is 88, and hypoplastic left patients from birth were 57, and 31, they were considered immediately to a biventricular repair from birth. And from this 57, some of them require comfort and died from sepsis or post-transplant, and go to the stage 1 surgery in 54, and 7 could be recovered to the biventricular circulation. So from the 100, we have 43% of live-born with biventricular circulation after fetal aortic valvuloplasty from this kind of patient. So in the probability of survival, if the hypoplastic left heart syndrome 10 years, you have close to 70%, and that biventricular repair close to 100%. And the surgical strategy of the Boston team is different than what we are doing. After the fetal aortic valvuloplastic, they prefer to do a Norwood procedure with restricted ASD, plus aortic valvulotomy, mitral valvulotomy, and fibroelastosis resection. All these just during the first surgery. And Glenn is, if necessary, sometimes you don't go to in the second stage to the biventricular repair, and sometimes you perform the Glenn surgery to give more time for the left ventricle to grow, and then the biventricular repair after maintained with a small ASD. These are some of the pictures of the reconstructions in some cases of hypoplastic left heart syndromes after the hybrid approach and the comprehensive stage 2. We are using a homograph to connect the pulmonary trunk to descending aorta and the arch vessels. And here is the diminuted ascending aorta. Of course, this is not a patient to go to a biventricular repair. And concerning the pulmonary artery distortions after the stage 2, this is our biggest nightmare in this situation. So the exit angio is extremely important to define what to do. Usually in the right side of the pulmonary artery, we have better results with augmentations, with some resections to control the stenosis after the PA band removal. But usually in the left side, as I mentioned, the placement of a stent is considered, in our opinion, the best option. This is probably Simone had shown. This is our experience in H-core from the 46 fetals with fetal aortic valvuloplasty, with 5 fetal deaths, with 11 neonatal deaths, and 30 neonates survived, and 65 of them were treated with the biventricular repair, and 10 with univentricular repair with the strategy that we had just related to you. So this is one of the cases, 27 weeks, the first day, and after the hybrid, 5 months, we can see that the left ventricle is growing. And we can see after the biventricular repair in 24 months with a very good left ventricle, as we can see here in this picture. So we have sometimes late complications after biventricular repair, like left ventricle dysfunctions that could be systolic, but usually diastolic left ventricle dysfunction, the aortic or mitral valve dysfunction. And we might have all efforts to preserve the valves in a reoperation. The ASD approach, we can close or augment it, and Kaka had just shown the possibilities of doing that with intervention procedures. And we might lead sometimes with aortic arch or coarctation restenosis, and we can use surgery or catheter intervention to treat. Why is this important? Because the left ventricle dysfunction could be treated or clinically with beta blockers, inotropes, or any other type of vasodilator sometimes, but the catheter intervention can treat and exclude all left side residual lesions. This is very, very important for the best follow-up of the patient. And surgical treatment can include the left side residual, the treatment of the left side residual lesions, the implant of a VED, or sometimes the heart transplant that we had been performed in 2 successful cases of these ones that are recovered after fetal valvuloplasties and after biventricular correction, and we might consider the possibility of the transplant that was successfully performed in 2 cases. This is an example of a case, a recent case, a child with 1 day old with hypoplastic left arch, hypoplastic arch, aortic arch, and coarctation, and a huge and very large PDA. And with a borderline left ventricle, we decided for the hybrid approach. And this case has no fetal intervention. And here's the left ventricle in comparison to the right ventricle. Here's the left and the right. So this patient was considered to a hybrid approach that was performed with 2 days of life. It was right and left PA bending, PDA stent, no dilation of the aortic valve. The child had a good recovery. He was discharged at home within 20 days after the hybrid approach. With 11-month-old with 9.5 kilos and the saturation of 95% in the upper part and 79% in the down part of the body, it was considered a biventricular repair. Evaluation was done with NMR. We can see that the left ventricle is quite better than in comparison to the right than it was in the beginning after birth. And this is the angiographic study of the left ventricle with all the pressures, measurements, and all the other images that we need. So we consider a good case for biventricular repair, not the best, but a good case. And the surgery was performed with the bending removal, the left and right PA augmentation. And after that, there's the placement of a stent in the left PA, the stent removal, reconstruction, and augmentation of the aortic arch, aortic valvuloplasty that we have performed is the commissurotomy and the shaving of the valve in the very thick valve. And we kept an ASD of 5 millimeters. The child had a good recovery, was discharged from hospital 15 days after with a normal, considering systolic and diastolic left ventricle function. What happens is that 30 days after discharge, the child began with symptoms of cardiac failure, no weight gain, and tachycardia and tachypnea. And the echo showed an ASD shunt from left to right with a good systolic function, but a very impaired diastolic function. In the cath lab, it was attempted ASD closure, but it was identified a high diastolic pressure, and the ASD was kept open, and the child was clinically treated. No other images was done in this cath lab, but then after that, we decided to perform a CT scan, and the recoartation was identified. Here's the stent in the left PA, and a recoartation was identified. And this child went back to the cath lab, and here's the coartation, and here is the placement of the stent, and was a almost immediately improvement of the diastolic function and no more clinical symptoms. This was done 4 months before, and now the child continues to have a good recovery with a remarkable better left ventricle function. Just to illustrate some cases, some experience with biventricular repair with no fetal intervention. This is a team from Korea with a recent publication in JACC from 67 patients with hypoplastic left heart being considered for single ventricle operations, and 6 for palliative and bridge to transplantation in 4, and 45 were considered directly to biventricular repair, and 1 for a hybrid approach for the staged treatment for a biventricular repair. From the 12 concerning 2 other biventricular ones, it was possible to have the biventricular circulation alive in 45 of the 67 patients. So it's a very inter experience. And this is another experience from the team in Gießen of Akin Turk, who's the surgeon, Dietmar Schanz. You have the hypoplastic left and variants, 154 patients, and patients with biventricular correction were 40. These are the diagnoses of the patients, and 4 patients with fibroelastosis 10%, and 21 with discrete or long segment aortic coartation. When we can observe is that the probability of survival of these patients with biventricular correction and in 14 years is around 83%, and the probability of freedom from intervention of biventricular repair is around 63-64% in 14 years. And we saw that there is the aortic valve score, the mitral valve score, the aortic valve diameter, and the mitral valve diameter improved after the correction, and even the length ratio of left ventricle and right ventricle is considered okay. So in summary, we can say that we have different surgical options to approach the borderline left ventricle. We might have an adequate pre-op imaging that is mandatory for decision of the best procedure. The fetal intervention brings the left ventricle to a better condition, and usually the hybrid approach is indicated to treat these patients to recover the borderline left ventricle. The post-op evaluation after biventricular repair needs to be effective to identify recent residual lesions that could cause impairment in the left ventricle function. They are all complex cases with need of multiple procedures by interventionist, surgeon, and all members of the team. So thank you very much. This is what I'm planning to show you.
Thank you so much. A beautiful presentation from the eyes of the surgeon. Now, the floor is open for discussion. Norman, I'm sure you have questions.
Well, yeah, more than questions. I think that was a stunning presentation, Dr. Jetin. Thank you very much. Everything was absolutely clear and beautifully articulated. The only question I have is that this discovery of the diastolic dysfunction abnormalities is probably not a new phenomenon, but it's unmasked by the fact that you've removed so many of the other problems. Would you agree with this?
Yes, I agree. We had problems to understand immediately what had happened with this child. We had checked at the echo. I think Simone had done some of these echoes, and we have checked the pre-discharged echo, and the functions were described as a very good one, even the diastolic function. So after 4 weeks to 5 weeks, in a control echo, because of some changes in the behavior of the child, some new symptoms, the diastolic function was considered bad. Probably it was a progressive impairment of the diastolic function because of the progressive recoartation. So slowly and step by step, the recoartation was becoming more small, and the diastolic function was impairing time after time. So it was a good decision, in my opinion, to study this child as all methods that are possible, and to have, I don't know how will be the follow-up in the next month or in the next years in this specific child concerning the diastolic function, but it seems to be better, and I think we can have a good open possibility of a good evolution.
Excuse me,
Thank you
sorry,
very
this
much.
patient has endocardial fibrinostosis, the one with diastolic dysfunction, or any, predisposing factor?
This patient, we didn't resect fibroelastosis. It was considered a mild fibroelastosis in very specific points. It was not a concentric fibroelastosis in this patient. So that was not. Concerning fibroelastosis, Rima, we are always discussing with Simone and Carlos about what is better for the patient. Is it better to remove the fibroelastosis in all patients, or is it better to keep the fibroelastosis if it's too not important? The problem is that to remove fibroelastosis in small kids is not an easy thing, and especially in borderline ventricles. We have 3 possibilities of surgical approach. One of them is the mitral valve. Usually the mitral valve is borderline also. So to reach a good area of the left ventricle by the mitral valve is not an easy task. Another option is to go by the aortic valve. So usually the aortic valve is a valve that was dilated, has stenosis. Usually it's a biventricular, it's a bileaflet valve. And to have space to open the valve and to achieve the left ventricle outflow tract is not an easy task also. And sometimes we might, when we have the decision to resect the fibroelastosis, we might use, as I showed in the movie, we might use the apex of the left ventricle. And sometimes the 3 combined approaches, trying to resect a little here and a little there. So one of the patients that we had to perform the heart transplant resected the fibroelastosis, and with no left side ventricular, left side residual lesions, the diastolic function was impairing with the time after time, and there was not any more fibroelastosis, and the systolic function was good in the beginning, and after that it becomes worse. So it's not an easy decision. The best situation that we removed well the fibroelastosis was in a child that we had performed the Ross procedure. some years after the biventricular correction because of the aortic valve that we have just done 2 other previous surgeries, and now we need to replace the valve. So when we remove the aortic valve and the aortic valve and the aorta, we have a very good exposure of the left ventricle by the aortic and the left ventricle outflow tract, so we can resect better the fibrinostosis. So I think it's a discussion that we can have for a long time, but we must use all the efforts and all the information that we have to decide what is better to do. I hope to have answered the question.
Yeah, beautiful. Simone, the diastolic dysfunction, I forgot. What was the anatomy in that case? Because that's very important. And as Dr. Silverman said, it is expected. A ventricle that's not really optimal on borderline. But the question is that it did not appear early. It appeared a little bit late. So that was a borderline hyperplast with an aortic valve stenosis and an abnormal arch, or what was the anatomy of that case?
So that case, I even saw her in utero, this baby in utero, and as a fetus, the baby had a bad coarctation, and in utero was a mild aortic stenosis, and this baby had some spots of EFE, and the ventricle was borderline. And then he had the hybrid procedure, and he needed a balloon valvuloplasty because the because of the aortic valve stenosis progressed. So he had a combined disease, coarctation, bicuspid aortic valve that turned to be severe and with time, but it's not an unusual ventricle presentation. It was a very special, different case that took us a lot of discussion, and so you see how this obstruction lesions can damage the ventricle.
And even Marcelo said after surgery, the coarctation increased as probably due to the diastolic dysfunction, or not? The flow was...
Yeah, I don't think that increases. I think one thing is not only diastolic dysfunction. I think they have diastolic dysfunction and they don't tolerate any residual lesion.
Okay.
So the arch obstruction that was progressive, the requartation, fibrosis, and things like this, I think made the baby feel worse because of the ASD, because of the left atrial pressure that was increased. And you see everything is together. So if you close the ASD and you don't relieve the obstruction, the baby won't be wean off the ventilator because of pulmonary edema.
And the ASD was tried to close. Kaká tried to close the ASD during the cath lab, and the diastolic pressure increased a lot. I know Carlos remember the case, and so he decided not to close it anymore, and we tried to investigate and try not to keep in the cath lab for a long time, and so we tried to treat clinically, and then it was identified some days later the recoartation.
Thank you so much. I think we kept you all late. Well, it depends where you are in part of the world. So you have a midday in Brazil. I would like to thank you on behalf of the Congenital Heart Academy for sharing your time and knowledge, and our audience for staying with us. And also, I'd like to say that this is a recorded event. It will be found in the YouTube under Fetal series. You can always click and watch it. I'd like to thank Dr. Silverman for being the godfather of this series, and see you soon sometime, as we say in Arabic, inshallah.
Inshallah.
Hopefully in Washington, okay?
Yeah,
Yeah,
Washington,
yeah,
D.C.
please
We'll be
do,
there.
please do. Please do. Thank you so much.